Well, good afternoon and happy Health Professions Week. This is the culminating event, and today we're very fortunate. When we have Health Professions Week, we always try and ask a nationally recognized speaker to come talk, and today we are very lucky that we have two internationally recognized speakers that are right here from Wichita. They work at the Structural Heart Center, the Structural Heart Program that is over at Ascension Via Christi in St. Francis. And today they're going to talk about medicine in the age of artificial intelligence and digital transformation. I want to tell you a little bit about them, and I'm going to get out of the way because I know they have a lot to say and you're going to be really interested in the topic. Dr. Brett Grizzell from Wichita Surgical Specialist is board certified cardiothoracic surgeon. He is skilled in minimally invasive surgery and transcatheter aortic valve replacement, TAVR. Founding member of the structural heart team at Ascension Via Christi St. Francis, and also serves as medical director of its lung cancer screening program. He was raised in Wichita and received his doctoral degree in medicine from the University of Kansas School of Medicine. He completed a residency in general surgery and a fellowship in cardiothoracic surgery at Washington University Barnes Jewish Medical Center in 2011. Dr. Basum Chehab with Cardiovascular Consultants of Kansas is board certified in internal and cardiovascular medicine, specializes in complex coronary interventions and structural cardiovascular interventions, received his medical degree from Lebanon University in Beirut, and completed his residency in internal medicine and a fellowship in interventional cardiology and cardiovascular medicine, it's a long title, at the University of Kansas Medical Center in Kansas City in 2012. He developed an extensive background in research, having worked on multiple pivotal clinical trials and research projects and being involved in pioneering work on TAVR and other minimally invasive procedures. Dr. Chehab was recruited to Wichita to join Dr. Grizzell in the development of a multidisciplinary structural heart program at St. Francis, where he now serves as medical director for the hospital's heart valve clinic and structural heart program. So please help me welcome them today, and we look forward to hearing their presentation.
Thank you for joining us. Does that sound all right? My name's Brett. I was coming here to talk to you about artificial intelligence, and then I was almost ran over by your Starship food delivery system. I realized I'm already out of my ballpark. What Dr. Chehab and I do, and especially what I do, is very significantly invasive. I open up somebody's chest, I stop their heart, I open their heart, cut out their valves, and extensive recovery. Maybe a couple weeks in the hospital, 2 to 3 months without any significant activity. Just getting up to walk is a big challenge. So what we do together, though, has revolutionized the way people get treated. The problem is we're not cutting them open anymore, putting a cookie cutter sizer in there and saying, what size of valve does this patient need? We're going through maybe a 5mm incision in the leg, and we have to duplicate exactly what I do in surgery over a small wire. And Dr. Chehab's going to talk to you a little bit more about the tools and the technology, so how we know what we need to do without even being there, really. And that's important. Another part of what I do where artificial intelligence is important is lung cancer. So just for example, Ascension today had 450 scans, CT scans performed. And they do that about every day. So, and then about 10 to 15% of those every week have an incidental finding. So we have about 500 scans that come up with a mass on the lung throughout the entire Ascension system in Kansas that needs something done. Can you imagine the resources it takes for those 500 scans to be called out to those 500 family doctors to say, you need this done. This is concerning. It needs to be looked at. That doctor has to talk to those 500 patients. They have to be set up for other surveillance. And it's an overwhelming amount of resources. So I would actually encourage anybody in the audience that's interested in that to come follow us for a day when you're designing these systems. I know there's a huge innovation campus here. And come, how do we make those processes more efficient? So that I'm actually talking to the patient that needs me rather than looking at maybe 390 scans that are really nothing. That's what computers are doing for us today. They're actually smarter than we are. If you take 10 CT scans and you know their lung cancer and you have a computer that has used artificial intelligence to understand what cancer recognition looks like, they're going to beat me every single time. Five out of 6 surgeons will pick up the cancers 80% of the time, and the computer will do it 90% of the time. And that just shows you the vast amount of information and actually cost savings for healthcare, better healthcare, and allows everyone to practice at their scope of what they really need to do. And that's kind of what I think about the next frontier of artificial intelligence. And then every time I buy something on the internet, I realize artificial intelligence will say, hey, you need to buy this too. So everybody else that bought this. And when we were preparing for this speech, we realized just how much artificial intelligence is already around us. And then you guys tried to run me over with your food truck. So this is what the structural heart is. This special room right now is what we call a hybrid room. Traditionally, you either went to the operating room or the cath lab room. Well, this room is set up with both of those technologies. It has a CT scan built right into it. You can see that thing at the head of the bed. That's a CT scanner, the regular operating room lights, and then a regular cath lab suite. And that's what we built approximately 11 years ago. And at that time, these things were $5 to $10 million per room. But that allows us to do our vascular interventions in there, Dr. Chehab and I to do our structural cases, and then it allows, we can even do open heart surgery in it. And that's kind of what it took. And the same thing with artificial intelligence. What you're taking is you're taking the best skill sets of each division, putting them together, working together to have a better product. And artificial intelligence is going to allow us to do that much more accurately and also quicker, less healthcare cost. So we started in 2011, and just like anything, you have to have an idea and a vision, and that's what this campus is really known for, is that innovation and how do you combine education with business, and you should all be very proud of where you're attending college. But we started off with the vision in 2011. We built that room in 2012, and we started doing cases in 2013, and those were on the aortic valve. So traditionally, the problem with the aortic valve is the valve becomes too narrow. So we were able to use computer systems, CT scans, to look and to see how tight those valves are. And that calcium that makes those valves too narrow is actually used to hold a new valve in place. So that's what we call TAVR. And then if you look at what we call MitraClip, if you think of the mitral valve as 2 French doors that open back and forth, sometimes the door jambs get pulled too far, so things leak between. Sometimes the door hinges break. So the MitraClip, we can go through the leg and actually put the 2 doors together so it starts the process. So the body, it's like starting a zipper. So when the body's blood flow hits it, it automatically stops. These abnormal flows back and forth through the heart is what causes heart failure. And if earlier you detect that and treat that. So those patients come in and they go home the next day. Compared to the gentleman I did this morning where I repaired his valve, he'll be in the hospital a week. And these therapies were really, really designed for, let's say, our 80-year-old family member who may have fractured their hip, maybe they can't walk across the room. But those were the therapies were really developed in the minimally invasive to get them out. And those therapies became very effective in that population of people. We're able to start using it in much healthier patients because they work. And that's where we're at today. You can see here's a list of studies. A lot of these things some of these things are the first done in human beings in the world right here in Wichita. And that's because of this collaborative arrangement of teamwork and these big companies that are doing the same thing you're doing here on this campus working together. So Dr. Chehab and I are actually very excited about the future of your and our relationship about designing these valves, implementing care plans, and how do we change healthcare? This lady right here in the very top right was from out of town, but she had one of the first valves placed in the world. It had been done in animals before, but she had the first valve placed in the world in her. And she went home a week later, and she couldn't walk across the room. She was getting ready to be on hospice because there was nothing that could be done for her. Dr. Chehab talked to the FDA, says, "We think this will work. Let's give it a shot. Can you let us use it on a compassionate basis?" They said yes, and that's how these things start. Then we went on to the transcatheter mitral valve replacement. This is a short video. So here's your heart. It's beating, and all this is done with wires. So we're coming up from the right side through your leg. That's the septum that it's going across right now. And we're going to put that wire on the right side of your screen. You see that thing that looks like a parachute. That's your mitral valve. That's the French doors I was talking about. The problem with the mitral valve is it didn't have the calcium burden that the aortic valve had on it. So we didn't know how to keep it in place. So we're going to make something that looks like a car spring here. That car spring is going to wrap around all those parachute cords, go around all that, and that's going to make basically a dock for us to put a new valve in. So we're going to take the technology that we learned from the aortic valve, where it was all calcified, and we're going to put it over here on the mitral side, but it won't hold there if we don't put this dock there. So Dr. Chehab can do all of this by using echocardiography and fluoroscopy. Now the future of what we're going to talk about today is how do we design systems and how do we figure out who can do that, how do we do that more effectively. So now we have the dock in place. So now we're going to go back 15 years ago to where we knew what we were doing in the aortic position. So we're going to cross that dock, and we're down in the left ventricle. And now we're going to bring a valve that was designed 15 years ago and has worked great for the aortic position. We're going to flip it upside down so blood flow goes the right way. And now we're going to put it in the mitral position. There's only a few centers in the world that are doing this. And this is just spectacular. So a busy cardiac surgeon, and you know, if you didn't know, the world has a shortage of engineers, healthcare providers, doctors, nurses, echo, paramedics. But a busy cardiac surgeon like myself may be able to do about 250 of these a year open. And that's really doing a lot. With this type of valve system, that same surgeon, with Dr. Chehab's help, can do 500 of them and through the leg. Now you have a functioning valve. You just have to make sure you put it in the right way. This is the mitral valve repair. It's very similar thing, but the heart basically has 4 valves. It actually has 6 valves, but 2 of them stop when we're infants. But it has 6 valves. So mitral valve repair is what we're talking about. We can actually go in there and put new parachute cords into the heart. Same thing through a catheter. This is where I was talking about the door hinge just broke on one of those. We're going to come in there, we're going to grasp that, and we're going to put a new parachute cord right down in there. The thing about this that's much better than what I'm doing is I have to stop the heart, go in there and cut that open. This can all be done while the patient's awake. Now, early trials we're doing it while they're asleep, but they're awake, the heart is beating, so you can fine-tune it to the millimeter that you need. Instead of me measuring it on a heart that's not beating, we're fine-tuning it, we're looking at the echo, and everything's perfect. Same thing on the tricuspid valve. Different technologies, and everybody's designing these, and all these computer systems, and all this artificial intelligence is asking us. So every week, Dr. Chehab gets on a weekly call, says, what do you think about this? There's only 5 people in the world that can do this. What do you think, Dr. Chehab? Can this be done? Well, we're all going on that. But now we're building 20 people. We're building 100 people. Now we have 100,000 people. We have 100,000 data set points in this system that we can enter. And now these computers can start to help us say, who can this be done on? What's the most limiting factor 90% of the time? So then we go to the School of Engineering and we say, this is 90% of the time why this can't be done on somebody. Dr. Chehab talks to his partners across the world and says, fix this. And they do. And these patients go home the next day. You can't see the good-looking guy in that picture, but that's me behind the guy in the black hat. I'm going to let you talk, Dr. Chehab.
Thank you, Rick. So he got the cool part and the cool pictures. I'm going to start talking about the dry materials. I apologize. So thank you, Dr. Hand. Thank you, everyone, for having us here. We're very proud of our partnership with WSU. I just finished these slides like yesterday or the day before. I apologize. I was in San Francisco. So I just forgot to introduce my disclosure, which I have a lot to disclose about this. So my name is Chehab. I work at Ascension Via Christi. My disclosure are as follows. I'm a board member of the governing system of the FDA. So I'm an HSS federal employee. I'm on the governing board of the NIH, or the National Institute of Health. These are the ones relevant to this. I work with a lot of AI platform and companies. I'm the project manager for the Helios 1 and Helios 2 with Microsoft, working on their AI system. I'm the project manager also of Cerebra, which is the AI software developed with IBM. And I'm also a member of the Simplicity Task Force with the European AI Consortium with the Dassault French Industries. So, so I'm definitely biased on this. I'm going to try to keep my bias to the minimum. So AI, it's the reason I got into this is because of all the stuff we do in cardiovascular. And the whole idea is we cannot see what we're doing from the outside. We're not cutting the patient open, though the idea is how can we develop algorithm and platform that can analyze what's going on inside and give us a better predictive model of how we're going to be performing these tasks on a repetitive fashion without any issues. So AI really, we expected that as we grow artificial intelligence, we are going to be really influencing a lot medical practice. And I think medicine and healthcare has a lot to learn from AI. There's a lot of things that we have faced after COVID with the staff shortage that really kind of forced our hand to expedite our projects. And actually, we got way more funding to expedite them because we lacked staff. So a lot of the menial kind of work that we used to use people power to do, we start to outsource to AI and try to minimize our reliance on a human factor, what we call. This way we have better optimization of our staff and human resources to do it. I mean, if you look at AI, I mean, really, it's growing like crazy. This is the list of publication that you see from AI just in the last few years. And as you see, it's like massively. The amount of PubMed publication just on AI with a simple search has grown exponentially more than anything else. So really, but before we start working with AI, we just have to set the problem with some basic rules on how we're going to do this. I mean, you hear a lot of stuff about there's no rules about AI, it's not regulated. Yes, it may be not well regulated, but there's a lot of rules that we have set in the last few years just to make sure that we're heading in the right direction. And there's a lot of principles in here that we have to talk about that are very important. And you know, most of them really depends on how can we have a universal connectivity, how can we go and preserve human rights with these systems, how can you use AI and to maintain information security, you know, public health interaction and administration with this, how it's going to relate to our AI systems. And you know, there's a lot of interoperability or interchangeability with the system. You don't want to design one system that works with one kind of platform. You want a system that can talk to each other. So there's a lot of rules we have to discuss and really make sure that the ethical part of what we do is maintained as much as we can. So before we go to this, so AI, you know, AI, people hear about AI, but AI really has a lot of definition and a lot of levels of AI. Not each AI is equal. AIs are really quite different, and they can be as different as multiple siblings in the family. Each one has their own personality. So really, AI is intelligence demonstrated by machine. That's the simplest definition. And really, technically, it's intelligence that is mimicked and by machines as cognitive function that a human has, and thus giving you some learning and some problem-solving solutions. So different level of AI, you know, there's artificial intelligence that is narrow, general, and there's super intelligence. This is really a very simplistic kind of cartoon on what it is. And you know, our ideal AI and what we thrive to, even though every time we're not there, it's just right slightly behind that middle ground where the green dot is. We really don't want to develop super intelligence. We don't want to even get to the general intelligence, because the more you get to that part in a non-regulated fashion, the more the danger can happen. Granted, there are some industries working on a higher level of AI, and we are part of them. I'm not going to lie to you. But really, the main goal that is accepted by most consortium is going to be right where that green dot is. And these are the levels that are defined by Nick Bostrom as superintelligence. And you know, and this is really where we want to be on our system. So you hear machine and deep learning. There's different level, and this is how we teach our AI time after time after time. I have spent countless hours just trying to teach them and adjust and recorrect. And you know, and there's different kind of learning process, and just really like it's like you're a teacher in lower school or in middle school trying to teach kids. And it's very basic concept. There's supervised learning, there's unsupervised learning for AI, and there's reinforced learning, as you can see here. And then there's the deep learning process, which really is really where it makes you possible to analyze very complex data sets and then allow the machine to learn by itself without really any human interaction. So definitions, again, it's all about understanding what we're doing in here. Big data, we all know what big data is. It's a large amount of data that's pulled from everywhere to be used for analysis. Very important. And this is the reason is to do precision medicine. That's why we're doing all this in healthcare. And precision medicine is when we have to, we can tailor guide the therapy to the specific patient or to the specific strain of a virus or to the specific, you know, pathology and disease in a predictable and easy fashion. So artificial intelligence and machine learning are pretty similar, but deep learning is when the machine requires less structured data to learn simultaneously. And then this is described as a convoluted artificial neural system. So deep learning is when the machine now is able to do convoluted tasks by itself with, like I said in an earlier slide, without any minimal human interaction. And then you go to the simulation world because teaching machine requires simulation. So that's how it's run. You teach it by big data and you teach it by computational simulation or CS. And that's how you create these data and you allow this machine to build these algorithms to grow more from reality on how stuff are done. Extended reality and virtual reality, augmented reality, and mixed reality are all part of the simulation. It started early on by just doing an extended reality. It got introduced more, as you see, to virtual reality and augmented reality. And the simplest form of virtual or augmented reality, the difference, augmented reality is like the HoloLens, where you can put goggles on you. You can still see the surrounding world around you, but you have extra data input that allows you to analyze reality in an augmented fashion. And really, it's like Iron Man. You know, when you look at Iron Man, he can still see everything, and he has all the extra stuff in front of him. That's augmented reality. Virtual reality is the absence of the current reality and just an imposed reality on you. And these are the ones that Meta has, the Meta goggles, where you're completely blind. If you can walk through a wall, you're not going to see it. All you can see is just the imposed reality on you from this system. So, but good and bad, there's differences on which one is better than the other one. And that's why mixed reality came in as one of the newer platforms right now in the last few years, where it just involved all three of them in one platform and allow you to toggle between augmented reality, virtual reality, and then, or both at the same time, depending on how you want to do it. That gives you more processing power and more accuracy on how you do stuff. So, why are all these important and why is AI important? You know, because what we need in cardiology is we need to make sure that what we do is predictable and safe for the patient. And we need to know ahead of time what is the best therapy for the patient. And unless we have an open chest and we're working directly with the vessel, we are unable to do that prediction. So because we're working from far away, and that's why we need this simulation to see what it is. And you know, the applications for that are very important when we use like computational simulation just to figure out stenting of the vessel. What is the best way to stent a vessel? How can we predict if the stent's going to be good or not? How can we make sure that the stent's not going to fail? How can we figure out what size of stent we use, what length of stent we use? So there's a lot of potential platform and application for CS or computational simulation for coronary artery stenting. As you see in here, it can be pre-procedural planning. It could be stent research and development and building better stents that last longer and fracture less and have a better radial strength. It could be in design of virtual clinical trials, which really we think in medicine that may be the most promising part that we are looking for, is instead of running these clinical trials to approve a device or a drug, and it costs millions and billions to run these trials, we can perform these trials in a simulated fashion in a virtual reality through the help of AI and deep learning and save on the cost significantly of these trials. And you hear a lot about, well, big pharma make a lot of money and, you know, a drug that can cost $50,000 per pill for cancer and this is unethical. Well, just because no one understands how much R&D was done and the cost of these trials to get this drug in the market. Well, if we can slash that cost of R&D by 90%, then we're going to slash the cost for the patient by 90% plus. And that may be really the hope on how we're going to start doing and helping the healthcare system right now in the US, which is really heading into an Armageddon kind of moment where we're going to end up running out of money because of the cost of healthcare and the cost of technology that has grown like astronomically. So this is why, as from a federal standpoint, the VCT or the virtual clinical trials or that concept trying to build that system, that's why we're invested so much, looks like the most promising thing we can do to really help the system and help the patient get to where they need in a safe way without really breaking the bank. And then, I would say, in my opinion, the second best is education. How can I be using these applications to educate patients? And I'm sure you've seen this in a lot of university and center. There's a lot of reliance right now on education, from virtual reality, from simulations. I mean, like, anatomy classes right now are not the same like before. I mean, in my days, we used to go, quite frankly, buy a dead body or someone donate that to us, and we're like dissecting that until there's no tomorrow because that's the only one we can have. And if we screw it up, I mean, tough luck. That's the only one you had. Right now, you can do all this in a virtual reality center. You don't have to really desecrate any human body by doing any studies on them. And, if you make a mistake, reset and do it again and again and again and again. So really, the learning curve in medicine has gone dramatically up because of the power of computational simulation and AI for education and training. I mean, even right now, I mean, most of the stuff that I do go from animal research right now to virtual training to human kind of concept, like that evolved that Dr. Grizzell talked to you. I went from a pig named Willie that was implanting in Santa Clara the week before to a virtual reality kind of simulation for like 6 hours where I got my hands wet in the virtual reality, and then to the actual human implantation. And I think that phase in between helped me a lot, just try to have some basic concept on how that should be done versus just getting my feet wet directly without knowing what we're doing. So plenty of workflow, plenty of application. It's a very exciting time. Being in 2023, 2024, in this next 5 years, having the chance to be involved in these new technologies is really amazing. And there's so many applications for someone who's really willing and want to learn these. The sky is the limit. It's like going back to the time where they invented penicillin that had tremendous effect on the population of the planet for a century to go. And we expect that this is going to have almost similar thing because it has tremendous application. So as you see in here, just simple example. We can do pre-stent simulation anatomy. I can just have the system by itself look at the vessel on the CAT scan and tell us exactly where the blockages are in A. In B, it will tell me how the flow in the vessel is. I'm not even inside, I haven't even seen the vessel. I don't even know what it looks like. It's all images. I can predict flows, know which one has better flow versus the other one, and how the flow turbulence is that can affect stent thrombosis. It will tell me the nature and the quality of the vessel. Is it a calcified vessel? Is it a fibrotic? Is it a fibrocalcific? It can analyze the nature of the wall just by scanning the area and can tell you which one needs further therapy, which one is going to be too stiff to put a stent in, which one needs further therapy. And then you can simulate stents and how much you're going to put them in the body up to a few millimeter difference. You can visualize the flow later on, and you can visualize exactly what the stent effect was before and after you were done by looking at this simulation. So bottom line, what I'm trying to say is you can have a patient and you will scan them. The system will analyze all this automatically and will tell you, well, if you put a 4 by 12 millimeter stent between this zone and this zone, that's the benefit you're going to have on this patient. And that's the one that we have predicted to have the best outcome on flow compared to other locations where you're not going to maximize your flow. So really, this is a concept that goes beyond anything we're doing right now. Right now, it's more like best guess, operator judgment, basic guidelines. And really, as you see in G and H, the actual stent and in HD, virtual stent prediction is almost similar. So there's a very strong correlation between these assessments. So it help us, again, plan on doing complex stenting when there's a bifurcation and the vessel have 2 loops. I mean, the vessel is one, the stent is one loop. So how can you reconstruct that? What is the best method? It can allow you to give you very specific and patient-specific computational simulation. This way, you know ahead of time what method is going to be the best for this patient without even having to go try the first one and I say, well, I wish I did this. One of the most things I hate in practice in medicine is when I do something for the patient and I think I'm doing the right thing and then the final result, you know something? I don't like it. And I think I wish I did the other method. Well, there's no wishing in here. All these are done ahead of time. All these computational analysis are done ahead of time. And we can see what's the best thing for the patient and what technique way ahead of time. This way, all you have to do is just go execute, deploy the stent, and be done. So the human factor is still there. You still need the human being and the doctor to go and get the stuff done. It's just all the other processes, all the other potential scenarios that may or may not work are already pre-analyzed and labeled for you, and you know ahead of time what you're doing. So this was from coronary standpoint. Another application is what we do exactly in structural heart. Or structural heart is treating patient with valvular heart disease or major structural failure of the heart. Like, valve failure, valve leakage, valve narrowing, holes in the heart, and everything. And one of the biggest challenge we have is, again, we can't see the valve. And these systems allow us to simulate valve deployment based on CAT scan and tell us which one is going to be the best one to open up the vessel, give you the best flow, minimize complication, minimize stroke risk, minimize pacemaker read, and everything. So in A, as you see this simulation, all this is done ahead of time. And that image will be overlapped on your X-ray as you deploy in the cath lab or the hybrid. And all you have to do is just go put the valve right where the picture is. I mean, come on, my 6-year-old can do that at that time. It's not that difficult. So it's trying to really to make it less dependent on human factor and human analysis and make it more accurate for the patient. In B, where we repair mitral valve, we go and we put clips on tissue that is like 5 millimeter thickness. So many times we have tissue that is weak or substandard in quality. So as we put these clips on them, it tears the vessel, it tears the leaflet. And now we have completely damaged the valve, we can now repair it. Computational analysis also, AI, allowed to analyze data that we have from the big data that we have provided, and will study by itself the nature of the quality of the leaflet and tells you which area of that valve has the strongest and best leaflet composition that will take your clip without damaging the valve. So you have to go just put it there and be done. So many different applications, so many different potential that we work on, and it takes time. The problem is the way to build this is we need to collect data. Data has to be built to algorithm. We need to have the algorithm start working, and then they start, and this is like the learning, supervised, unsupervised learning, going all the way down to deep learning by itself. So we need to keep coming back and correcting what they are analyzing. And this is the last phase, is when they start analyzing and we start correcting, and then we resubmit the correction. And as we keep correcting the mistake that the AI is doing, it gets more accurate and more accurate and more accurate. And by the health thinking definition, we defined a viable AI as 94% of human accuracy prediction. So as we need to get to 94% target to be able to say, okay, we are close to human prediction to start to go solo. And this is like the Tesla auto-driving stuff right now. There's a reason it's not completely operational yet. You still need the human factor because they're not at a certain margin that says it's human-like. For medicine, we've defined it as 94% of human accuracy. Most of the time, we're around 84%, right now 85%. You're going to say, oh, wow, we're close. But learning is exponential on these systems. So it's very easy to go from 30 to 50% learning. But when you're going to get to 85 to get to 94%, that takes many years. And this is really the most difficult part. And I always try to explain that to people. It's like charging your battery. It's easy to charge from 0 to 80. You use less power. But as you want to charge from 80 to 100%, it takes a lot of power to finally charge and finalize that battery. That's why the iPhone doesn't charge. It charges to 80%. The last 20% I'll charge later in the evening to have less carbon footprint when there's less demand on the power. That's how Apple has set it up. Same thing for machine learning. So we have a long way to go, but it's going. So, and this is what I'm trying to say is why CS is very important. It's because it helps us simulate medical device development. And this is really one of the most important things we do. And this is really, the hope is going to be the biggest cost benefit in medicine is by the ability to get to a point where we can predict the outcome of a certain trial in a virtual environment without having to run it on people. You know, if one of the most traumatic things we remember recently about trials is the COVID trials and the ethics and legality of running these trials on kids to see if a COVID vaccine works or not. Well, the whole idea right now is you don't have to run it anymore on people. God forbid it's really not the right therapy. And then you can run it in a virtual scenario, way cheaper for like a fraction of the cost, and then end up with almost a very accurate analysis as you had run it in reality. And that's the hope, is to cut down the cost. And when you cut down the R&D cost, when we cut down on all these, that saves us a lot of money. I remember in my trainings, I was tasked to study a stent, and it's called the supera stent in the leg. And we were studying the structural deformation of the stent and how strong the metal platform and the alloy is. And we want to make sure that the stent does not fracture with repetitive flexion. So I used to buy, or we used to go get cadaveric leg, implant the stent in the leg, take it to a flexion machine, run it for 1 million, 2 million cycle, explant the stent, study it under the microscope, and see where the fracture point happened in the stent. I hated that job. I spent so many days and so many weeks and years just working with dead legs and under the microscope with these. And all I remember is the voice of these machines flexing these legs day after day. Well, that costs a lot of money to do. So when the stent is approved, it's a very expensive stent right now. Right now, we can do the same work I did 15 years ago in a virtual environment for free, for a fraction of the time, fraction of the cost. So when that stent's going to become commercial, it will be hopefully very, very cheap. And then the only one who's going to benefit from this are the patient and the healthcare system at this point. So these are very important concepts, and that's why this VCT is a very important concept. So as you see in here, there's a big spectrum for extended reality. So beyond the computation analysis, we talk about virtual, augmented, and mixed reality. And as you see in here, we can just be sitting, and I can be sitting inside a stent and simulating that. You can see exactly, instead of having a microscope to study the fracture point and see where the alloy was weak, I'm like touching it almost. And that's the beauty of this. And I can walk through a stent. It's unbelievable the feeling you have when we're doing these kind of things and how much it had made our life easier. And quite frankly, I have a better understanding. I think seeing it like this, my brain can visualize it and understand it better than me just trying to do a microscope, and I can barely understand what I'm looking at. So it really had made our life so much easier studying this technology. So extended reality, which is what we talk about, virtual, augmented, and mixed at this point, a lot of benefit. And it can go from education to actual interaction. I'm almost involved on every one of them. As NG, I have very few, a little bit interaction. I'm more of a consultant there. Holoscope and True 3D, I'm deeply involved with them. And I'm going to show you some holoscope kind of holographic simulation of surgeries as you do them. And I'm not involved in this one. HoloLens with Microsoft on the primary project, and this is the Helios 1, Helios 2, where we're trying to develop deep neural networks for simulation of tactile feedback and visual feedback for surgeries. And that's pretty complex, and that's a joint venture between Microsoft and SpaceX, because we're using their links with Starlinks. So and then the Atlas of Human Cardiac Anatomy, that's one of the most things that's available right now, and the virtual heart. These are the main two things for anatomy right now that students study anatomy and do stuff like that. So the holoscope, this is what the holoscope is right now, and it's just a prototype. And it uses holographic imaging to analyze and allow you to just project images, and you can hold it in your hand, and you can do whatever you want with it. You can cut it, rotate it, analyze it, study structure, all this done through a holographic feature. So I'm going to, see if this will work, this video. So real view holographic pictures. So this is the heart. It's like open heart surgery. It's right in front of you. You can study the anatomy. You can open up vessels. You can pick the vessel that you want. You can add the vessel that you want. You can check any valve you want, all in a holographic fashion in front of you when you're doing your surgeries. So the goal from this is a step-by-step approach for the surgeon as they do open heart surgery in that training. So he has the heart cut, and then it's projected in front of him, step by step, what is the next surgical step. So he will see, I have to cut this, and he will do the same. I have to open up this, and they'll open up the same. I have to suture here, and he will suture the same. And it's all like overlaid directly over the heart and in real time. This is like an example of, like, for me, for valves. It tells me exactly where to put my valve, and it's just overlaid on my heart and then on the chest of the patient. And I can do whatever I want. I can deploy the valve, see the effects in a virtual way. And the hope from this is to improve the learning curve from education to get and be better faster and in a much easier way than just years and years of training.
I teach a lot of residents. One of the things that's interesting when you're teaching residents is when we stop the heart only has so much time to be stopped. So I'm very interested in this technology to not only make myself better, but someday a computer will tell me, what 50 moves could you have eliminated to get through that quicker? And they'll take these over and over and over. And when I teach residents to operate on the heart, they can't spend a bunch of time. So this technology will not only make students better, it'll make me better. If I can reduce the time that patient's heart stopped by 30%, just by eliminating unnecessary moves, that patient's going to do significantly better. Their kidneys and brain and everything's going to work a lot better after heart surgery. So I'm deeply interested in how Dr. Chehab and his team do this. I do think he should disclose to you that his 6-year-old and his 8-year-old and his 10-year-old are far better at these tools than he is.
That's true. So actually, that's a true story. So part of the project with Microsoft is they're trying to develop what we call AirPlay, or these tactile feedback. So what I do is, for example, our project is like I peel a banana from here to Stanford or in Cambridge. And like we peel a banana, and it has to be repetitive, and we have to suture it back, and we have to feed the tactile feedback. So what we learned, one of the best way is, so now they gave my 12-year-old, 13-year-old, and my 10-year-old, because they love Xbox, it's Microsoft, so they made a virtual controller where, my son has the HoloLens on, and there's really no controller. He's just playing, and it's like air movement. And he's playing like Fortnite or Call of Duty and all this. And they're using their neural feedback to adjust the system, and just from a game. So they're the coolest kids in school, by the way, just by doing this. And they have all the friends that they want to come to play with this. So, and he's right about this. And they do way better. There's something about them and how their brain is, they just can catch up with these stuff way faster than us. So HoloLens is an augmented reality system, like you see in here. And it's another system that allows us also to do, it's not holographic, but a projection in your reality that comes in and allow you to see what's going on with the patient. Like, if you're trying to aspirate an abscess on patient chest, usually you'll see none of this. All you see is the green drape. This one allows you to overlap exactly based on CAT scan where the system is, and you can go directly and you see this red dot, and you can aspirate it and get it out much faster. You can overlap the patient anatomy on the patient. So this is the patient behind, and this is the whole skeleton and kidney. And if you want to do a kidney biopsy, you can see directly. The system projects for you the track of what is the safest needle access and preventing you from going through major other organ causing complication. the best way and best pathway to get to it without affecting anything else. All you have to do is just follow that line. Again, stick your needle. Anyone can do that. So imagine how much easier that's going to be and how much helpful that's going to be. And, definitely, augmented reality was augmenting what you see by adding more information. We can see whatever we want from the system. I've watched Fox News one time while doing an animal thing. It was amazing. So you can overlap whatever you want. You want to see what the stock market is, you move it in, you see what the stock market is, you move it out. Oh, let's see what the pig is doing, bring back the pig picture. So you can do whatever you do in reality, and that's the beauty of augmented reality. And I'm part of that board with many people with the company. So plenty of examples from healthcare and how they can benefit from AI. It improved in-person and online consultation. It has health assistant and medication management. AI can really find a lot of the options to improve medication compliance with patients and analyze their habit, their sleep and wake pattern, and their activity day to day to find what is the best timing for their medication to minimize non-compliance, which is a massive burden on the community right now and a big problem with patients not taking properly their medication. AI-driven diagnostic, which is one of the most scary parts for most physicians because they feel threatened is going to take their job, is when AI can do all this. And one of the examples is rapid AI, which we already have in Wichita here, and this is the one that Dr. Grizzell used. It's called rapid AI, and it allows you to study X-rays and CAT scan and do radiology work and do the preliminary analysis without a human interaction. So that already have cut down a lot on the system by using rapid AI. Mining of medical record, this is a no-brainer. We've been doing it for so long. We have data that we have systems that sniff medical data and sniff records through EMR or imaging. And then let's say, hey, how many patients have I had yesterday that had anemia? Or how many patients have I had yesterday that had aortic stenosis? And the system every night will send you an email and update you. Red flag, red flag, red flag, potential patient, potential patient. And then you look at your data and say, well, this guy was treated, this guy was not, and he's going to give you missed 3 patients. These patients came to the ER, they had aortic stenosis, no one paid attention for them. Can you please call them back and take care of them? So these are what mining of data, medical records is. Very important tools, very important, very important pathways for help. Precision medicine, deep genomics is a massive project that looks at this. I'm not involved in this, but deep genomics is really looking at precision-guided medicine through through vector targeting of DNA and RNA strands to help cure a lot of medication. Designing treatment plan. I mean, you've heard all about this. It's IBM Watson. Right now you can go and a lot of healthcare, a lot of many clinics use IBM Watson for diagnostic, and then it allows you to you input your symptoms, and it spew up a few differential and with the most likely one. It still has some inaccuracy problem. It's not completely there for prime use, but that's the most advanced thing we have right now from designing treatment plan. Drug creation, this is a big thing, and this is something that you guys should be involved in, I think. So drug creation and device creation is very important. To design a molecule, to design a chemical compound takes a lot of trials back and forth and a lot of information. So having an algorithm that can sniff through all the data and through all the potential permutations that see if this is a chemically stable or chemically unstable compound is very important. Then using AI and deep learning is very important for drug creation, cutting down a lot of the time on R&D for research and for development, and then again, hopefully for the cost. So there's a synergy between, if we talk about AI, computation simulation, and augmented or extended reality. So, and they all interact together. AI depends on CS. CS will spew out ER. ER will give you more data and more data generation for computation simulation, and then it's a loop, and that's a constant learning. And once you get to the self-feeding loop is when the system becomes independent, where it starts learning from itself, and it's like, and we start calling it at this time, this is really the upper level. This is like the supercomputer where machines start teaching machines at this point, where you don't need to have an input of human to really keep that circle closed. Because right now, I have to close every part of the circle. Once that becomes a self-feeding engine, this is when it becomes independent. And now a machine can start teaching a machine and vice versa. And this is really one day the potential outcome from this. So there's a lot of limitations. So ASER is the acronym for AI, simulation, and extended reality. So all three of them. There's a lot of data biases. There's a lot of legal obstacles. There's a lot of pending lawsuits or court holds on a lot of the patents and IP that people have. It's very, very expensive. So there's a lot of financial barriers. The hope on how we're explaining this is there's a potential benefit to drop down cost and time in the future and really work with the economy to minimize the reliance on human factor for workforce. So that's one of the hope on how we're going to do it. There's a lot of technical complication and technical consideration. A lot of things that are not really unanswered yet, like just this tactile feedback I'm talking about with CS that we're building requires a lot of computational power and a lot of supercomputer power. So it's not easy done to relay 4D and TS or tactile simulation in a real-time fashion. So really, on the right side, I want to really end with this virtual clinical trial pathway on how important and how that pathway has already been pre-labeled, predefined with the FDA, with CMS, and with the NIH. This is really the basic core thing we're trying to do right now and the basic algorithm on how we're trying to achieve this. And, you know, you guys are living in a very interesting time. People say, well, what's the next thing that I'm going to be in? What's the next thing to latch onto? Should I be an influencer on YouTube, or should I be a cryptocurrency kind of guy? This is the thing. If you're here in WSU and you have these programs available and you want to grow more on this, that's a great thing to latch on. Someone who's really interested in this, we can help them out and connect them for more internship. And with some of these companies, if they want to do something like this, we can help you out and create the right pathway to hopefully help you grow and realize bigger potential. So again, thank you very much, guys, for having us here. And sorry for this very dry talk, but it is what it is. That's AI. So the question is the VCT or the virtual clinical trials would eliminate all the human trials or the people trial versus just be solely dependent? Is that a myth or not? So the whole idea is yes and no. So right now, there's no way we're going to get into a point where it's completely human or user-free. But instead of spending 10 years and 100% by hands-on clinical trial, we can do the first 8 years virtually and then finalize it just with 2 years of human and in-person kind of trials. So that cut down on the length and the cost significantly, and that's the hope from that.
And that first 8 years may take 33 seconds. You know, that's what's fascinating about this. Once these things start learning, and you can do that. Right now we have heart models that we have beating in a simulation lab that give us 20, 30 years of what this heart model looks like on an expedited heartbeat system. And it takes 5, 10 years to get through a lifetime of that. These models will be able to generate that data in 5 minutes. So it will speed up the evolution and the progress of medicine. And once the system's costs are absorbed, it's going to significantly reduce the impact or the financial impact to grow.
So that's I'm going to give one example. Again, I'm going to go back to that stent I work on dead legs. It was 4 years of my life to finish that project to get to a result. So out of curiosity, at some point a few years ago, I inputted the same stuff in the cerebral system. It came back with the results in 34 days with the same thing I did in 4 years. And I can tell you my heart sank. I was going to like kill myself. So just the differences. And I think as computing power and data grows, it should be faster as time goes on. So the question is, if the AI will be a supplement or a specific field for education. So AI is still not part of education yet. It's ER, it's extended reality, augmented reality, mixed reality. I don't know of like significant AI except basic regular AI, which is like what we call simple AI, that is in charge of this. So right now it's all an ER kind of thing where you can do things and learn things, you can learn surgeries without really having to experience it on people. So I don't think we're there yet to supplement anything, but at some point the hope is, and I know there's certain people working on this that I know who are working to take the educator out of that, which means you have the student or you have the user trying to do a surgery, or let's say do a retina surgery on someone, because these are like very dangerous stuff. Sometimes people, they lose sight. And they see his pattern of behavior, and they have all the data with them and all the algorithm, and then they input correctional thing for him how to do it. It's like you have someone who's like guiding you and say, well, it would have been better to do it this way, or this is the next step. So it's not there yet completely. It's really far, I think. But the whole idea is the AI role in this would be just to keeping it as a closed loop and taking the educator out of that.
There's going to be two pathways. There's going to be the people that develop this, and those are going to be the new educators. And then there's going to be people like myself who implement it. And if I could implement that and just save a career full of mistakes and learn and have systems there to put me back on the right track, it's amazing what this is going to do for education. I mean, it's absolutely amazing. The surgeons, just in my specialty, are going to be far better in the future with this kind of technology. If we ever do surgery again, if Dr. Chehab just doesn't put my family out of business, I'm probably. But when we do that, we're going to have these models where I can't see these models like they are presented here. He can actually turn a heart. I have to cut it in half, 3 different ways to see the backside of that heart.
And I can do it 20 times.
I'm going to be able to look at that. My anatomy, my understanding of anatomy is going to be so much better. And the residents of the next 10 years, the fellows that are learning to do heart surgery, their learning curve is going to be much different and much safer.
The question is, will it drop the cost of education? Would Harvard still be $80,000 a year if you have a virtual system and a lot of things are automated? Because right now, really, I mean, there is, believe it or not, there is a bias in the population that is getting educated. And there are what we call them invisible people that are really not getting the chance to get the proper education. And through many factors, through many reasons, social, economical, whatever it is. But no one should not be able to go to a Harvard kind of like education just because they can afford it, or just because they only have a spot for 100 students. Well, guess what? If you automate this, we can teach 1,000 for half the cost. So it's really opened up a lot of options for a lot of these social issues we're having, and hopefully open this up in a fair way to everyone, no matter what color, race, crazy you are, poor, rich, whatever it is. It really bring it in a fair way to everyone, and everyone has a skin in the game to make it better.
If I had to start medicine today, I would be heavily involved in this. And on the flip side, I would take more courses in communication. How do you learn empathy? These computers are not going to be able to do that, at least not today. So the next 20 years, the successful physician is going to have a deep understanding of this artificial intelligence. They're going to have great person skills. They're going to be able to deliver a speech.
Not us.
Yeah,
not us.
We're talking about what we want to be. But that's, so you get this automated world that is so far away from the human touch, and medicine has to keep up with that, or nobody's going to want to go to the doctor, no matter how smart they are. You've got to be able to communicate to people, and those will be the next Bill Gates of the world, in my opinion. Those people that can take this high-tech stuff, deliver it to people in a compassionate world with empathy. And if you put those three things together, I'd love to be your agent.
I'm telling you guys, I envy you, your age and the time you're in right now. I'm too old for this at this point, and I'm delegating this to a lot of people who do this at this point, but I envy this. I mean, I wish I can come back right now in this day and age and know what I know and just have the opportunity to be one of the leading and in the center of this at a younger age. I started this at a very older age. It wasn't even available at my younger age, but I envy you. You have a lot of potential. Someone who really has interest in these, the sky is the limit for them, and there's going to be a massive demand for them in the future. So that's very fair. So the comment is, we don't believe that it's going to drive down the cost, but it's going to make it more efficient, and that may be true. I mean, we're doing this with the best intention to do this, but from how we know how CMS is structured and the cost structure for healthcare is, the biggest expenditure, if you analyze the current data we have, is on R&D. The reason you're paying $100,000 is because of the cost of R&D. It's not because big pharma are greedy. They are greedy, but they're not that greedy. It's really because they want to pay back the R&D cost that they had, and this is what it is. There's a greed factor. They want to make that much margin to this. So that will never change that margin. If anything, they're going to increase a little bit when they are making it cheaper. But if you drop way more your cost for production for R&D, the hope, and it's a hope, and I may be naive in this, the hope is to drop down the cost universally and make it better. Now, malpractice is one of the limitations I had on the slide before. There's the legal and the ethical part of it. We don't know how this is going to play. Right now, you already have a rapid AI system, or you have AI in medicine. The way we are mitigating malpractice, it has to be finalized by a human user at the end. Someone human has at the end to review what the AI has said and sign on this. And once you sign on that, you assume liability. Up to that point, you're not liable. No one has signed for that. So the way the system is designed right now is a human liability as the final person who signed on that report, and you'd assume liability. How that's going to progress in the future, that's one of the challenges we have, and there's going to be a lot of legal work that we have to figure it out, and we do not have the answer for that.
I think your point is very valid, but I take it a little step deeper, and we don't know what level of quality we're getting now. If you just look at those 12,000 CT scans for lung cancer that I'm talking about that came up this month in just one hospital system, it would require me to hire 15 full-time employees to look at those CT scans, navigate that patient through the system. So my argument really is maybe our quality is, maybe we won't cost less, but our quality will be significantly improved, and the time it takes to get people through that system will be improved. So maybe it may actually cost more, but people will receive better health care. But I think your point's very valid, and it's something that you're going to have to see play out. But I think that the quality is going to go way up when you can look through that much information that quickly and get patients to the right place.
Actually, it may be the opposite. I mean, there's some predictive models that look at and they say, if this becomes operational the way it's expected, it's actually the humans who are going to get more lawsuit than the AI, because they're doing more errors than the AI. But we'll see.
We have time for one more question. Yes.
So you have a lot of students going through college health professions now. What, aside from an internship and some research, what can they be doing to start getting into this industry and working with the AI?
They just need to, it's a great question. So what can you do as a student to be part of that new wave of technologies? And that's something that we have to talk to the school and what they currently have. I really don't have any visibility of what they have right now. And I don't know exactly what kind of courses and what they are and what kind of degrees they have in this. But there's a lot of pathways for help. Either we can grow it locally or we can outsource them and send them to more internship outside to complement that training. But I'm lacking the information what they have currently here exactly to make that judgment.
On a very small scale, let's just say somebody was interested in these CT scans that I was discussing, and they like that kind of information. I'd love for them to just come look, spend an afternoon with me, and just look, because the problem is we don't recognize what we don't know. So you take a very bright student that loves doing this kind of stuff, and they come and say, well, here's the problem I have. I have 50,000 data points to enter. How do you fix the system, guys? And they will, because I don't know what these students know, and they look at my problem in their world, and they fix it. And that's what collaboration that I'm looking for. So on a small scale, if there's a student that wants to do that, I'd love to have them come follow me for an afternoon. Maybe they come back in 3 months and say, what do you think about this idea? And I know Ascension's big into that kind of endeavor too, because maybe we don't have to buy the next system from a $30 million system from somebody. Maybe it needs to be developed right here on this campus.
Can we thank Dr. Grizzell and Dr. Chehab for the presentation? Happy Health Professions Week. Have a great weekend. And thank you for coming. Thank you.
Thank you so
Thank you,
much.
sir.
I tried my best.